So we're here at the iwNHL, and we just had a very action-packed session on novel targeted agents in lymphoma that I think was very informative, quite controversial. We covered a lot of ground. Maybe I'll start by asking you, John, what you thought about the session and what was the highlight for you?
Well, I think for me, probably the most important thing coming out of that session is there's a ton of work, a ton of active targets that are being explored, small molecules, antibodies, etc. So nice to see outside of CAR-Ts, there's still a lot of activity. I think the challenge has been identifying the right patients and the right subsets. And so some of the targeted agents, again, I showed some data looking at an XPO1 inhibitor called selinexor, single agent activity reasonable, trying to place that now in context with combinations or earlier in the disease appears to be the big issue there. I think the other thing that I was struck by in particular was the data looking at the TG compound Umbralisib, where kind of seems the story there is more about its action not on PI3 kinase but actually on CK1, and so an evolving story there about drugs that may actually target multiple pathways.
I think it was actually intriguing that we've got a lot of tools now to look at some of the targets and understand them a little bit better before we actually put these agents into the test. I mean, I think the key is going to be a lot of the preclinical data to try and see where we can prioritize them and select the right patients. Otherwise, we might miss the signals of activity. But Kieron, you spent some time talking about double hit and triple hit DLBCL, which again is a very challenging patient population to treat. But did you come away with any clues from some of these targeted agents as to what we might actually be trying to bring into that difficult to treat patient subgroup?
Yes, I mean, I think we have a lot of agents that are potentially active in that subgroup of patients, including Selinexor, where there is some good activity in double hit patients. I think this afternoon we'll hear about CAR T-cell therapy, but I think it's an interesting story that a high proportion of patients on the diffuse large B-cell lymphoma CAR T-cell studies have double hit or double expressor lymphomas, and early results, show that they seem to be doing pretty well. But I think it's a real challenge to pick the optimal agent to combine with immunochemotherapy in that subset of patients.
I think there are trials planned ultimately with venetoclax, which, do you think that that's going to be rational moving forward?
Yeah, I think it is. I think one of the challenges has been toxicity, combining it with immunochemotherapy, and you just want to be careful to not compromise your ability to deliver optimal immunochemotherapy. That's always a challenge when you're adding new agents. But I think it's very promising, and the Alliance group have planned a study in, I think, both double hit and double expressor diffuse large B-cell lymphoma. Yeah.
We did, in an earlier session today, talked about, the ideal clinical trial design given all these agents that are out there, and yet we still spent a lot of time in this session focusing on individual sort of histological subtypes. I mean, would you like to see some of these drugs broadened out in trials that are all-inclusive for non-Hodgkin lymphoma? How are we going to handle that?
I think the advantage of being able to do that it'll certainly accelerate the ability to put people onto studies. I think the struggle in large cell lymphoma in time seems to be the people that get onto the studies are maybe not exactly reflective of the patients that we see in the broader population that we treat. And so, the example of looking at people with, MYC rearrangements, you see varying outcome in some of those patient populations. And so, studies that hopefully allow us to maybe give some therapy in the frontline setting and then get higher risk, sicker patients onto trials will allow us to better reflect the population that's going to be looked after moving forward.
Yeah, I think it's really important in the upfront setting to keep in mind the International Prognostic Index, because if you look back over the last 30 years, it's always predicted who does well and who doesn't. And I think that we've got to combine that with molecular markers, which are very important. But in terms of designing studies, I think we really need to focus on that population of large cell patients who have high IPI scores, because I think that the biggest difference obviously can be made there. And even consider confining certain studies to high IPI patients.
Yeah, when you think about it, so we've got this wonderful treatment called R-CHOP for diffuse large B-cell lymphoma, and if you are curing 70% of patients with that, it's hard not to keep that as a backbone as you develop novel therapies. And we talked about whether or not that was the right or the wrong strategy, but I think for the time being, we will likely be stuck trying to add things into R-CHOP. But if you take all comers from the get-go, you're really giving extra toxicity to about 70% of patients that don't actually need that drug. And also, it's not surprising that we might miss the signal activity if you're adding it into all comers. So I think we do need a strategy of selecting high-risk patients and, as you said, the right biological subgroup who's going to benefit from that agent that you're adding in. I also spent some time in this session talking about Polatuzumab in relapsed refractory DLBCL. We now have a randomized phase 2 that compared Pola and BR versus BR alone in DLBCL. And for a group of patients that really has limited treatment options, I think the data was quite striking, with high response rates and most notably a significant benefit in terms of progression-free survival and even overall survival with the combination of Polatuzumab. So, we talked about that combination likely going to seek registration and might come out as a new option for diffuse large B-cell lymphoma. And one of the questions is, how does that change trial design moving forward, and what's going to be the future comparator for relapsed refractory DLBCL?
I think that's one that we're going to obviously struggle a little bit, because the challenge has been defining what a standard approach in those patients are if they're transplant ineligible or if they've relapsed. And so, BR has a convenient schedule and toxicity profile, and I know it's used in certain countries, but certainly in others it doesn't represent a clear standard. That being said, pragmatically one has to pick a control arm, and so I think it was, a reasonable enough decision.
Great. Well, I think, it was a remarkable session. I think it showed me that we've got a lot of work to do. But I think that, it was exciting that we've got a lot of novel agents in development, a lot of tools to be able to hopefully measure their activity in preclinical settings and to prioritize the right drugs and the right patients moving forward.